Many things affect your health and well-being. GPs tell us that a lot of people visit them feeling isolated, lonely, or stressed out by work, money, and housing problems. These are issues that can't be fixed by doctors and medicine alone. At its most basic, a social prescription offers the kind of help that doesn't come in a tube or a bottle. The idea behind social prescribing is to help you to have more control over your healthcare and find ways to manage your needs in a way that suits you.
I'm Dr. Michelle Lin, Scientific Chair of Ending Loneliness Together. Ending Loneliness Together is a national organisation that's formed by industry partners, academics, to really focus on combating loneliness across the lifespan in Australia. So loneliness is defined as a subjective feeling of social isolation. We do know that loneliness affects older adults, in particular 75 to 85, when it's a time that's associated with poor health and bereavement.
I'm Patricia Sparrow, the Chief Executive Officer of CODA Australia. CODA Australia is the peak body that advocates and is the voice for older Australians. We advocate for policy and social change to protect the rights, interests, and for all older Australians to have a good future. Our aim is really to ensure that the voices of older people are heard and that we amplify them to policy and decision makers. The one that everybody's probably most familiar with in recent times is COVID-19. That's had a profound impact on everybody, but particularly on older Australians. We actually found that older women reported more often through COVID-19 that they had an impact on their mental health. But also as people age, their mobility declines or their health declines and they're less able to get out and connect with people in the community. We find that it's generally people over 75 who experience the highest levels of social isolation and loneliness. Also, we see with the increasing digitisation of the community and society that older people are also experiencing isolation as a result of that. We see with banks are closing, people are wanting people to go online. That means people aren't out and about in their local communities connecting with people. We see that with post offices play a really key role. Anything that means that people are out and connecting with the local community is important, and the increasing digitisation, and as organisations such as Australia Post and banks are looking at their economic bottom line, we need to make sure that they're looking at their social line and making sure that there are local solutions that keep people connected.
I'm Paresh Dowda. I'm a GP and I work at Next Practice Deakin. Next Practice Deakin is really a progressive, innovative general practice where provide comprehensive, really try and focus on authentic person-centred care and try and do that using a comprehensive sort of team-based approach and using a technology backbone to support us to do that. In our practice, looking at loneliness and social isolation is really important. We look after a lot of older people. The way we do that is we use a screening tool called UCLA3, which asks 3 questions around loneliness, and that allows us to really identify people with no loneliness, a little bit of loneliness, or a high level of loneliness. So that's how we identify people with loneliness and isolation. We're actually finding, so of all our patients over the age of 65, 28%, so more than a quarter, have a high level of loneliness. So it's really prevalent. And loneliness is such a big driver of healthcare utilisation. So the Health Foundation in the UK did a study and found maybe a quarter of GP attendances, hospital attendances, may actually ultimately be driven by loneliness. So a really important issue to address. We're fortunate that we're also part of a practice pilot where the Primary Health Network has given us a grant and we employ a social worker in the practice full time. So what we do is, using this structured screening tool, identify people with loneliness. Those that score high, we then engage our social worker in meeting with them, spending really quite a long amount of time with them to truly identify their sort of holistic needs, and then based on those needs, start to look at how those needs could be addressed. Sometimes it's tapping them into volunteer services, sometimes it's getting them into other sorts of groups. Sometimes it's ongoing support from the social worker for a short period of time. So where we are now in our sort of approach to this is, I think we've got a good way of identifying social isolation and loneliness. It's what are the interventions, what are the community assets that are available in the ACT that we can utilise and leverage to help support people with loneliness.
Loneliness has detrimental impacts on physical health, in particular cardiovascular health, poor immunity, inability to regulate blood pressure, and we do know as well that loneliness has detrimental impact on mental health as well. Loneliness is an issue that's difficult to resolve even though it's commonly experienced, so it does need a whole of systems and whole of government approach. In terms of what we can do, I think all of us have a responsibility to actually resolve loneliness from the individual to community all the way to our policies that govern the way we live, work and play.
We need to see a range of things in place for people locally that are going to keep people connected at the local level. This can include simple things like making sure that bank branches or Australia Post are still open and supporting older people to go about their daily business and interact with the community more broadly. But we also need to see other ways that people can be connected with their local community. One of the things that our state coders deliver is a thing called Fit for Life, or in some states Aging Stronger. It's a physical activity program that people can attend. It keeps them strong physically, but it also again keeps them connected locally. There are a range of things that local communities do that we see with volunteer groups connecting people, social support type services in communities that people can attend and engage with others. We want to see as many of those things as possible, and for us to learn from what people are doing in one community and making sure that if that's successful, that we can see that occur in another community.
Hi, I'm Tracy Johnson. I'm the CEO of Inala Primary Care. We're a large GP practice on Brisbane's western outskirts, serving a community of really complex, interesting and multicultural patients. Social prescribing is a pretty historic thing. We do it each and every day. Each of us tell our friends where they can go to get help. Doctors, nurses and the people working in our team routinely talk to people about things that they can do to make their life better and have the wellness goals achieved that people really want. In terms of formal social prescribing programs, we really started our journey about 5 years ago, where we managed to convince our primary health network to fund a social worker to come and work in our practice. So they're there 1 day a week. They've extended that contract because the results have been so profound. We then built on that model and we said, what are the needs of our multicultural communities? Because they're often the most voiceless and they find it hardest to navigate some of the systems that are so fundamental to the lives that we take for granted. So we had a model that applied there for nearly 2 years. It was defunded because unfortunately this whole social prescribing space is still getting recognised, getting understood, but it was an incredibly powerful model. We've then moved into group-based social prescribing, so we've run a group for people over the age of 65, bringing them together and allowing them to actually talk to each other and bring in other people from our local community to talk to them about where services are provided. Both of those models have been temporary grant-based solutions, so what I would say is that whilst social prescribing is something we all do every day, we need to do an awful lot more of it to divert patients away from expensive healthcare options into self-supports and community-based options. But until we actually get the people resources and the IT resources to make these things easy to access and affordable and ongoing, we're never going to achieve the full benefits that we could, and that my team would tell you today their number one priority for funding in our healthcare system is in fact give us more social prescribing supports, because then we'll solve access block, we'll solve their workplace burnout and stress, we'll make patients better able to change their lives so that their housing, their lack of finances and things like that are not impacting on their health. So for us, this is actually a really high priority health solution that needs long-term funding.
It is first important to understand what social prescribing is and why it is so important in healthcare. Social prescribing connects people to the non-clinical resources in their community. It identifies and supports community resources and ensures those resources are as effective as possible. This includes identifying and supporting people in communities to contribute their skills back into their community. Health and well-being professionals are also provided with the resources that can help them offer personalised support to their patients.
For some time I worked in the UK. I actually trained in the East End of London, which, perhaps describe as the home of social prescribing. It's been happening there for a long time. So my exposure to social prescribing in the UK has been absolutely fantastic, particularly when we're looking at diverse communities, when we're looking at social determinants of health. It's really, I think it does two things. I think it firstly appreciates that well-being is so much more than health, and then it looks at how can you address that. So it looks at tapping people into resources that exist in the community, but doing that in a structured and systematic way to identify the resources, the community assets, the non-government organisations, the volunteer services, which may benefit that person, and helping them engage with those services, tapping them in, and really building their own sort of intrinsic motivation, address some of those non-clinical aspects which are also important ultimately to health and their well-being.
One of the other things that we see across all of the areas we work in is ageism. So people making assumptions about older Australians, what they might like, what they might want to participate in and what their skills are. We think it's really important in addressing loneliness and social isolation that we see an individual as an individual. We don't make assumptions about what an older person may or may not want to do or may not be able to do, that we support them to engage with the things that are of interest to them in their local community with people of all ages.
Social prescribing for the patient demystifies things that they don't have to understand on a routine basis. So for a lot of patients, they get caught up, like we all do. We understand our lives and how it works, but we don't understand other parts of the systems within which we routinely don't have exposure. So for them, they found the benefits of actually having someone help them get an NDIS funding package. They found the benefits of somebody helping sort through their housing instability. They found the safety that comes when somebody supports them through navigating their domestic violence circumstance or their elder abuse circumstance at home. They've found somebody that can console and help introduce them to new people, because for a lot of people, loneliness is a real thing. Loneliness is the equivalent of smoking 15 cigarettes a day. And for a lot of people, just the confidence to join a new group and reduce that social isolation is a big thing. So from a patient perspective, depending upon what sorts of supports they in fact need from us, they end up in quite different places, but the overall result is increased confidence, increased ability to navigate systems that help them live their best life, increased friendships, and increased trust that we as a healthcare system don't just want to medicalise them, we actually want to help them have the best life that they can have.
In terms of our health workforce, what we have to do is actually train people to identify loneliness. What does it look like? What are the kinds of questions that we ask? And how do we help them? So where do we help? How do we help people? Where do we send them? What can we do to actually help empower them to actually establish and develop meaningful social connection?
One of the things that we think is really important is that communities are designed in an age-friendly way. If you can't leave your house, get to the supermarket or get to your library or wherever it is that you're going, you can be quite isolated in a community. So it's important that the communities are designed in a way that people can walk smoothly on a footpath, sit if they need to take a break, that the lighting is good if it's later in the afternoon, particularly in winter. And we need to make sure that places like supermarkets, for example, are conscious of an older clientele and can support them with things on lower shelves and just support them to be able to do their shopping. That access is really important to keep people connected at the local level.
Implementing social prescribing is not actually a challenge. There are barriers, there are obstacles, there are things we need to consider. But in terms of, is this the most difficult thing that our health system needs to surmount? No, it's not. The number one thing that it requires is access to resources. And that's actually, in the full scheme of how many billions our healthcare system spends, such a tiny amount that it could be achieved tomorrow, and I'm hoping it will be. So other barriers that need to be addressed are things like who would do this work. We could in fact have peer workers doing it, we could have volunteers doing it, we could have social workers doing it, we could have nurses doing it, we could have all manner of people doing it. So as we create a movement around social prescribing, we need to look at who does what sorts of social prescribing, how would they be supported and trained, and what sort of pay rates would they be on, so that we in fact don't create a discontinuous system, but we create a system where career paths can be created and where training can be given and good employment can be the result. Another thing that we need is actually good digital infrastructure behind this, because if I'm a ready and willing social worker or nurse, I still need to know all of the contact details for all of the local religious organisations, all of the sporting clubs, all of the gardening clubs, all of the park runs, all of the other things that patients might want to access, and creating locally accessible, navigable digital systems so that they don't have to do a whole lot of research around that is something that needs to be created. And I'm really pleased to say there's a couple of solutions in existence that need funding to be localised, or solutions where people have scoped out the full need but haven't yet got the solution developed. Another thing we need is an evaluation. So social prescribing has taken off in the last 7 years that I've had an interest in social prescribing around the world. So in the UK now, in Scotland, in Ireland, places like that, Canada, the United States, there are thousands of people in social prescribing roles, tens of thousands if you added all of those countries together. What they haven't done particularly well is measure the results. So as we move this way in this country, I'd be saying we need to collect data and evaluate things centrally so we can actually measure the results. And the results will be things like patients can get in to see a doctor faster because there won't be as many patients turning up as frequently to deal with stuff that's not really dealt with adequately by a doctor. So we'll reduce access block. We'll be seeing patients get better, or at least not get sicker faster, because they're getting appropriate supports in their lives. So again, that changes the costs of the healthcare system. But we need to be able to demonstrate the value in moving money around our health and social care systems to make that work. The final thing that we need is recognition that when we start pushing patients away from reliance on a medical model, we're typically pushing them to not-for-profits in the social care sector. So we don't want to overwhelm those voluntary sector providers with demand, a lot of which they'd love to have more people participate, but they're going to need small and incidental amounts of money so that they can provide those gardening groups or those older person knitting sessions or whatever it is that they do. Some of those smaller social organisations are also going to need some support as people start using their services appropriately.
In Australia, when you speak to a lot of GPs, I think many will say they do social prescribing. I think we do to an extent. What's really missing in Australia is a structured and systematic approach to it. So I think when we do social prescribing well, it involves spending a lot of time with the patient. It doesn't have to be a clinical person that spends that time with them, but it's identifying needs. It's having a person who really understands what those community assets are that would help that person. And so if we're going to do this across Australia at scale, then I think what's really needed is for the policy really to facilitate that type of non-clinical worker within a general practice. They go by all sorts of names. Link work is the name used in the UK.
What are the key factors in effective social prescribing? Link workers are central to best practice. They are the professionals that connect the person to the community resources, and they need colleagues to understand their role well.
Our current fee-for-service system with the current Medicare arrangements is just not sufficient for general practices to do that. So it requires a new driver, it requires a new incentive, it requires new policy that recognises the value of social prescribing, B, support to practices to either directly employ link workers or similar, or via other organisations, for example, primary health networks, for them to employ the link workers, which are then co-located within general practices. And I think that would really allow us to move at scale and pace to do social prescribing.